Hi, I'm Hayden Hill.
Hi, I'm Rais Abrams.
I'm Jamie Crowley.
I'm Fazlin Idris.
I'm Wade Kerspay.
Our topic is progressive bulbar palsy, also known as PBP. PBP is a motor neuron disease which affects the bulbar region, also known as the medulla oblongata. PBP affects the bulbar innervated muscles and is usually associated with other motor neuron diseases like amyotrophic lateral sclerosis, Guillain-Barré syndrome, and myasthenia gravis.
Thanks there, Jamie. So I'm going to be talking about the causes now of PVP. So some causes could be muscle disorders, diseases or lesions of the motor nuclei of the medulla oblongata and lower pons. Could also be disease of the intramedullary nerves of the spinal cord, as well as diseases of the peripheral nerves supplying the muscles.
Thanks, Hayden. Signs and symptoms. The signs and symptoms include nasal speech is lacking, atrophy of the tongue, dribbling of saliva, weakness of the soft palate, dysphagia, difficulty in chewing, slurring of speech, and choking on liquids.
So our case study is based on a 58-year-old male who is a father as well as a husband. He lived for 2 years after finding out the first symptoms that he got. The family found that there was a lack of knowledge and information about the father's condition, and they had to find interventions and ways to deal with the father's issues such as pain. They also felt that practitioners were very insensitive and gave the family as well as the father a lack of hope towards his condition. So what we did, we broke down the 2 years in months, and months 1 to 6 he had very mild slurred in speech and got worse throughout the months. The practitioner then referred the father to only got the appointment for 2 months after he referred them.
Okay, at months 7 to 12, the neurologist ran tests which included blood tests, EMG of his upper and lower extremities, and lung tests. The patient started to see the speech therapist, which gave him exercises to work the muscles of the neck, jaw, tongue, and the face. The patient did these exercises a few times a week, and each session lasted 30 to 40 minutes. After some time, they noticed there was a deterioration in his ability to speak and swallow, and the doctor immediately instructed him to stop his therapy. When communication became a real problem as his speech deteriorated significantly, they then bought him an iPhone, and on that iPhone there was an application where he could write text in his phone and it would speak for him. So he used that to communicate with the doctors and the family. At this time, strength started to diminish, and what the family did to maintain the father's strength and help him with standing and sitting, they got him a lifting chair which elevated levels down to the bed and lower when you need to go low down. The family used bed risers to raise the height of the bed, as well as raise toilet seat with arms to make it easier for him to stand.
At months 13 to 18, the patient's hands and legs became extremely weak. The family got him big utensils so that it could make him easier to eat food. The family grinded his cereal, pureed his food, and got him to drink nutritional drinks or substances to make it easier for him to swallow. The patient started to feel suffocated and when he slept or lay down because he could not breathe through his nose. The family said that it seemed that the facial muscles started to relax, causing the nasal cavity to close more than usual. The patient couldn't sleep for a few months. The doctors then prescribed anti-anxiety medication, but it never worked. Family members recommended nasal strips which helped to open his nasal passages, which helped him sleep for short periods, which was usually 4 to 5 hours. In the 18th month, the family tried a more holistic approach and tried to slow down the progression of the disease. They tried a high antioxidant diet with no red meats and supplements with vitamins and minerals daily.
Okay, so from months 19 to 24, things got really difficult as dad couldn't speak at all. He couldn't consume thin liquids. Extremities were getting weak, especially on the right side, and new symptoms were appearing such as tight chest and panic attacks as described by the father. Cramping of the hamstrings, which were worse at night and mainly at night. Family then did stretching and massage to ease the father's pains and spasms. Medication that he got from the doctor, such as anti-anxiety medication, never worked for the patient, but he started on antidepressant medication at this stage. A big problem was now walking, because he struggled to walk around the house The family then got him a U-stepper, a U-step walker at least, and they installed grab bars and grip bars all around the bathroom and toilets as well as showers. Patient then started to fall frequently as he started to lose balance and because of the weakness in his extremities, and this then landed up, this caused him to land up in the emergency rooms a few times. They then, at the emergency room, then prescribed Valium, which was a good medication for him at this time. They also gave him baclofen, but it only worked for a week.
In the final month, the patient had the same symptoms and family kept trying new medication. The family also found a combination of medication that worked, but doctors kept prescribing other medication that didn't work. Eventually, the father ended up being in a hospice, and where they started sublingual medication until he passed a few days later. The family only found out that their father died of a disease called progressive bulbar palsy after the death of their father.
This is the argument based on our case study, and the literature we have gathered confirms our argument. The following are the signs and symptoms the patient presented with: slurred speech, deterioration of the ability to speak and swallow, weakness of the limbs, it affected the independent feeding ability, difficulty to swallow solid foods and later thin liquids, facial muscle weakness, laryngeal spasm causing narrowing of nasal passages, weakness in the limbs and spasms, as well as breathing problems and tight chest.
Literature shows that slurred speech and difficulty swallowing is caused by a low motor neuron lesion that causes the atrophy of the tongue, causing the tongue to have reduced mobility. Literature also shows that dietary changes must be made to allow the patient to adjust as the disease progresses. For example, solid foods are difficult to consume, thus food is liquefied thereafter. Weakness of limbs, mostly upper limbs, which affected his independent feeding ability, is caused by decreased innervation from peripheral nerves to the muscles they supply. Facial and neck muscle weakness, together with the loss of laryngopharyngeal nerve innervation, causes the airways to be constricted, which results in breathing problems.
Progressive bulbar palsy is usually associated with other motor neuron diseases such as Guillain-Barré syndrome and myasthenia gravis. We have come to a conclusion that the associated disease is amyotrophic lateral sclerosis. As the patient is of middle age and has signs of both lower and upper motor neuron lesions. The condition also explains the clumsiness and weakness found in the hands as the patient needed larger utensils for feeding, as well as symptoms moving to lower limbs in the latter stage. The average survival rate is usually 2 to 4 years, but our patient only lived for 2 years, which could be due to the lack of medical management he received. In latter stages, respiratory problems occurred as innervations to the diaphragm muscle, the intercostal muscle, the accessory muscle, which were all affected and is usually the main cause in death in this condition. This is due to pneumonia and respiratory failure.
Okay, we're doing the management for this patient based on our case study, so we're using the 5 principles of management, and the first one is referral. So the patient was referred to a neurologist by his practitioner. The neurologist, well, we felt the neurologist could have done further testing in form of an MRI, which can be done of the head and neck to confirm the lesion after looking at signs and symptoms. The speech therapist was consulted also to address his communication problems and weakness of various muscles mentioned in the case study. The patient could have also been referred to a dietitian for more effective nutritional information and advice. The patient should also have seen an occupational therapist to help with the ADLs or to assign a device that could help him with his independent feeding ability and assess his home environment to make it more friendly for him to use. He could also be referred to a social worker for financial aid and for counseling of the patient and the family. Physiotherapists can help to maintain the patient's current level of function as well, including strength, range of motion, chest expansion and standing and walking ability. They would also educate the family on patient's conditions and what to expect, and teach them the certain chest physiotherapy techniques and lifts and transfers that they could assist while we're not available.
Okay, so the treatment, Riluzole is the only available disease modification therapy. It can be used as an early neuroprotective treatment. The earlier it starts, the better. Medications such as Valium and baclofen can be used to reduce muscle spasms as well as muscle cramps. Antidepressants can be used as a way to make the patient emotionally happier and less depressed. And in later stages of the disease, antibiotics can be used for pneumonia.
During the rehabilitation process, the speech therapist would give the patient exercises for his muscles of his neck, jaws, tongue muscle and facial muscles. This would be to maintain the function of the muscles for as long as possible and prevent the deterioration rate. As physiotherapists, we can teach the patient techniques of swallowing therapy, such as the compensatory techniques, which is basically just postural positioning to make the action of swallowing much easier. We can teach the patient active movements to maintain the function as long as possible. Later stages of the disease involve deterioration of lung function. Therefore, we can maintain the function for as long as possible. When the function decreases further, then we can teach the patient's family assisted coughing and positioning to help prevent further lung infections and complications. If he is walking or walking is his highest level of function, we can give the patient walking exercises to do for about 10 to 20 minutes every day, which would increase his cardiovascular endurance. We could also teach the patient balance exercises, which would be static or dynamic stability exercises. This would help prevent the patient from falling when walking. The rehabilitation would be symptomatic and prevention of deterioration.
Prevention. The prevention of secondary complications such as pressure sores are done by teaching correct positioning. Chest therapy techniques are also taught to the family and should be done on the patient to prevent secondary respiratory complications. The patient is told to continue rehabilitation programs with the involvement of the family to slow down the progression of the condition.
Health promotion. It is important for the patient and the family to be educated on the condition and is made aware of what to expect in the later stages. A lifestyle change of both the patient and the family should be made to slow down the progression of the disease. It is also important to have community involvement and also education on the disease so that they know how to respond and to deal with the individual with this disease.
Okay, well, what I'm going to be doing now is just some percussions which we can use if there's secretions in the lungs. Obviously the positioning of the patient would differ according to where the infection lies in the lungs. So you just got to position him with a few pillows here. We're going to be teaching this to the parents, by the way. So a few pillows there, and then make sure that he's in the right position, as you can see. And then the percussion is just cupping your hands and leaving your wrists loose. And then, yeah, the patient must tell you if he's feeling any pain, or if he's coughing, then it's a positive sign for it's working. Okay, are you ready? And then you can also do vibrations and shaking if this isn't working to help the what's the name? Okay, so we're going to do assisted coughing for the later stages when he can't cough for himself because he's lost that reflex in his muscle, the innervation for that reflex. So you basically tell the patient to breathe in and then forcefully breathe out. And you apply pressure there from below the sternum, pushing up, so it's working where you're helping the diaphragm basically in its movements.